A multidisciplinary approach to the issue of risky driving behaviours in P-plate drivers, presented by myself, Erin, Dimitri and Sonja. It is estimated that in their first year of unsupervised driving, P-platers are 30% more likely to be in a car accident. This statistic is thought to be a direct result of young drivers engaging in risky driving behaviours such as speeding, driving under the influence of alcohol or drugs, carrying multiple peer passengers, and using a mobile phone while driving. To address this issue, this presentation will assess risk-taking behaviours in P-plate drivers from the perspective of educational and developmental psychology, forensic psychology, and clinical neuropsychology. Educational and developmental psychology centers on learning and development throughout the lifespan. Psychologists work with clients across differing stages of development and work in varying research and practice settings such as schools, hospitals, or community organizations. Within these settings, they treat individuals, groups, or organizations and may be required to work alongside numerous stakeholders like parents, teachers, or employers, or within interdisciplinary teams alongside other specialists. Like most psychologists, educational and developmental psychologists use evidence-based practice to assess behavioral, developmental, and mental disorders. However, they have a core focus on prevention by identifying and working with vulnerable people to prevent the onset of disorders that are later difficult to manage. Although inexperience is considered the primary reason for young driver accidents, recent literature and media accounts emphasize the significant role of risk-taking behaviors. Young drivers are more likely to speed, drive too close to the vehicle in front, use a mobile phone while driving, and drive under the influence of alcohol or drugs, along with driving in risky situations such as night or with multiple passengers. Recent studies have shown that even though young drivers understand the risks of these behaviors, they still partake in them. The etiology of risky driving in P-platers can be explained through the biopsychosocial model. From an educational and developmental perspective, social theories best explain risky driving behaviours. The theory of planned behaviour has been successfully used to predict and explain risk-taking behaviours in young people. It consists of 6 constructs that collectively represent a person's actual control over their behaviour. One construct, subjective norms, is the perceived social pressures to adopt or reject a behaviour and is strongly related to an internal belief of whether important people or popular culture think you should perform the behaviour. An additional theory is Burgess and Acres' differential association reinforcement, which is an extension on Bandura's social learning theory principles. Initial behaviours are primarily learned through imitation and later reinforced through either rewards or punishments. Differential association reinforcement has proven construct validity and can account for risk-taking behaviours such as smoking, drinking, and substance use. Both theories highlight the influence that parents and peers can have on risk-taking behaviours. The presence of peers can increase the occurrence of speeding, driving under the influence of alcohol or drugs, tailgating, and dangerous overtaking. Additionally, parental modelling has been found to be more predictive of youth risk-taking driving behaviour than parental teaching. Young drivers who perceived their parents as safer drivers were reported to be safer drivers themselves. Interventions applied through educational and developmental psychology are centred on prevention. When addressing the issue of risky driving behaviours in P-platers, there are 3 possible areas that interventions can be applied: through education, peers, or parents. Most education programs in Australia are voluntary and taught during the supervised learner and provisional licence stage. However, recent shifts have seen some states adopting mandatory pre-learner driver education programs. For instance, the ACT provides a mandatory road-ready pre-learner program targeted at school teens and new drivers. Driver education programs have shown positive outcomes. For example, young drivers attain their L plates earlier, resulting in longer supervised driving periods, potentially leading to the development of safer driving skills. However, some independent reviews have provided little support for educational programs reducing car accidents. Future educational programs should address current limitations. Many driver education courses cover the psychomotor, perceptual, and cognitive skills required of safe driving, yet don't emphasize how to apply these skills in risky driving situations. Moreover, educational programs may benefit from addressing psychosocial factors such as intelligence and peer or parental influences. With young drivers being more aware of the internal and external factors influencing their decision-making, they may be able to recognize and prevent risky behaviors from developing. However, these methods are yet to be investigated. Studies have revealed that the occurrence of risky behaviours increase when in a group, yet young driver intervention approaches for peer influences are limited. A trial intervention called the Speak Out campaign, developed in Norway, involves using education and mass media to encourage teen passengers to call out a driver if they feel that they are driving in a risky manner. The program had a positive response from teens and revealed evidence of a decrease in passenger injuries and death. Another proposed peer intervention is based on the principles of crew resource management. Originally developed in the aviation area as a means of enhancing communication and teamwork in emergency situations, it has been put forward as a young driver intervention aimed at developing communication skills through discussion groups, video demonstrations, role-playing, and other activities with the goal of improving in-vehicle communication as a way of influencing the positive and negative effects of passengers. A set of recommendations have been proposed for an ACT-based trial. The positive results from the Speak Out campaign and the potential of crew resource management-based interventions indicate that further peer intervention methods should be explored. Safer driving behaviours may be increased if interventions are able to equip teens with the skills to confront their peers in difficult and risky situations. Research has established that children can start to learn driving behaviours from their parents at an early age. However, despite their role, parents generally display poor driving behaviours and fail to define driving rules and expectations. As such, intervention approaches aim to improve parental modelling and equip parents with the knowledge and skills to successfully teach their teens safe driving behaviours. A recent parent-based intervention, Steering Teens Safe, is supported by health behaviour and family communication theory and has shown promise for real-world application. It is designed to equip parents with communication skills to talk about, demonstrate and practice safe driving behaviours and skills. And over a trial period of 3 months, it revealed an increase in parental engagement with interaction and supervision of safer driving skills with their teens. Alternative parent interventions have explored the impact of parent limit setting on young driver independence. Recent reviews have found that parents who set limits on driving privileges resulted in lower occurrences of risky driving, traffic violations, and crashes. From an educational and developmental perspective, risky driving behaviours and P-platers are targeted through interventions based on preventing or changing the behaviour at an earlier licence stage or through peer and parent influences. The current intervention methods discussed through this presentation show promising success for real-world implementation, and future research should further explore these methods. I will now hand over this presentation to Dimitri, who will assess this issue from a forensic psychology perspective.
I'm Dimitri, and this portion of the presentation will look at drink driving from the perspective of forensic psychology. Forensic psychology is a branch of psychological practice that is concerned with issues that connect psychology and law. While it has been given many broad definitions over the years, it has been stated that forensic psychology refers to clinical psychology applied in a setting within the legal system. Forensic psychologists can be found working in a range of settings, including prisons, jails, rehabilitation centres, police departments, and law firms, just to name a few. They may work directly with attorneys, defendants, victims, or with patients within the state's correction or rehabilitation centres. Generally, psychologists working in corrections may attend to the mental health care needs of inmates, including psychological assessment, individual and group therapy, anger or crisis management, or court-ordered evaluations. They may also consult with prison staff, inmate attorneys, advocates, and court systems on a variety of mental health related topics or recommendations garnered as a result of psychological assessment. Forensic psychologists may have to provide an assessment of an individual's competency to stand trial or provide expert testimony in a legal proceeding. They may also be asked to conduct a risk of recidivism assessment to gauge the risk of reoffending and provide a report of the defendant in order to inform the judge's decision on sentencing. Drink driving is one of the most important causes of traffic accidents. More than 50% of worldwide traffic-related deaths, particularly among young adults, are the result of drunk driving. In 2016 alone, there was a total of 1,295 deaths on Australian roads. Furthermore, 22% of all Australian road deaths involve the use of alcohol. Studies have shown that up to 15% of drink drivers reoffend within 5 years of their previous offence. Further to this, recidivists have been found to have a higher involvement in alcohol-related road deaths and other traffic offences. As such, it is increasingly important to target drink drivers, particularly their risk of recidivism, so that proper intervention techniques can be implemented in the hope of reducing drink driver reoffending and in turn reducing the amount of road deaths attributable to alcohol. Impulsivity and aggression have been implicated as fundamental in a wide variety of problem behaviours. Further to this, impulsivity has been strongly implicated in both aggressive behaviour and offending in general. Drunk drivers usually exhibit impulsive behaviours, indicating that they have problems in personality traits. It has been found that individuals who have high impulsivity scores have higher alcohol consumption and drunk driving attitudes, and that there is a relation between lack of planning, decision making, and sensation seeking with drunk driving. In addition to this, impulsive people are more impatient, have poor planning skills in regards to drinking domains, and are more likely to engage in irrational decision-making processes, such as hyperbolic discounting. In addition to these personality factors, Brown suggests that peer normative processes are also associated with drink driving. Research has shown that people who drink drive overestimate the amount of drink driving behaviours in their friends and are also less likely to perceive that their friends disapprove of drink driving. This suggests that explicit peer disapproval of drink driving may have a discouraging effect on drink driving or recidivism behaviours. DUI recidivism is related to a range of personal factors. It has been found that repeat offenders experience more interpersonal and intrapersonal problems, are more deviant prone, have greater levels of substance abuse severity, and are more likely to be unemployed. DUI recidivists are responsible for a substantial proportion of traffic offences, and some studies have reported that nearly 33% of known offenders will be re-arrested. Similarly, Headland 1995 reported that 20 to 28% of first-time DUI offenders will recidivate. These results indicate that DUI recidivism is a stable problem in a society and an issue that has to be addressed. Although high-risk drivers account for only 6% of driver population, they have a substantial impact on overall traffic safety. As such, the ability to identify high-risk drivers will provide a valuable reference for developing safety regulations and education programs. Risk assessment is a procedure used to estimate the quality and probability of the occurrence of various possible outcomes. As such, a risk assessment is a daily part of practice in most psychological settings. There are three main approaches to conducting a risk assessment. These are the unstructured clinical approach, the actuarial approach, and the structured professional judgment. Of the three approaches, the actuarial approach has been shown to have the most validity and reliability. The actuarial approach determines what risk category a person is in based on the presence of static and dynamic risk factors that have an empirically established relationship with the behavior in question. Static factors are characteristics of a person that cannot be changed and are predictive of reoffending. Such characteristics include age, gender, intellectual functioning, and poor upbringing. Dynamic factors, in turn, are characteristics of a person that can be changed. Such characteristics include association with deviant peers, personal distress, anxiety, low social achievement, and substance abuse. The more of these risk factors that apply to an individual, the more likely he or she is to reoffend. The purpose of conducting these risk assessments is not only to ascertain whether a person is likely to reoffend, but also to present courts with a report that may influence the judge's decision whether the offender is granted parole or a prison sentence. There are a range of programs that have been developed in the aim of reducing DUI recidivism. These include the Ignition Interlock System, DUI education, and victim impact panels, just to name a few. However, most of these programs have been found to be largely ineffective in reducing recidivism, or are effective during participation in the program, but cease to be effective once the program has been completed. For example, in a study looking at the effectiveness of interlock systems in reducing recidivism, found that when the interlock system was installed in the vehicle, the interlock group had a 60% lower recidivism rate than the control group. However, once the interlock device was removed, this difference in recidivism was no longer significant. However, evidence exists to suggest that multi-component programs are more effective than those which target only one aspect of the issue. For example, evaluations of the intensive supervision program, which consists of DUI education, substance use treatment, and a range of monitoring techniques, have consistently reported significant reduction in DUI recidivism. This may be because the multi-component programs offer several ways of changing behavior within the same program. This allows those who are unresponsive to one component to benefit from others. In summary, drink driving recidivism is a major contributor to annual road deaths. It has been shown that impulsivity is strongly related to drink driving and reoffending, and a whole host of dynamic and static risk factors are associated with reoffending. As such, multifactorial models of intervention have the most effectiveness in reducing recidivism. Now we will hear from Sonja, who will present a neuropsychological perspective on the topic.
Thank you, Dimitri and Erin. My name is Sonja Moon, and as part of our multidisciplinary response, the remainder of this presentation will analyse the issue of risky or dangerous driving behaviour in young adults, presented from the perspective of a clinical neuropsychologist. Central to the profession of clinical neuropsychology is the brain-behaviour relationship. I will therefore be examining the origins of dangerous driving behaviour from two neuropsychological orientations. The first one will be neurodevelopmental, with a focus on the effect of ADHD in young drivers, and the second point will focus on the involvement of drugs and alcohol in the dangerous driving behaviour of young adults. In conclusion, I will discuss the specific services available to address this recurrent problem. Attention deficit hyperactivity disorder is a neurodevelopmental disorder involving problems with higher order thinking and concentration. Driving a motor vehicle involves multiple complex cognitive actions, including perception, attention, motor coordination, and impulse control, all of which are impaired in individuals with ADHD, thereby compromising their driving ability. Several studies have found that individuals with neurodevelopmental dysfunctions, such as those with ADHD, were more likely to experience problems associated with driving, including more fines, accidents, driving-related injuries, and suspension of driver's license. One study by Ludoff et al. 2009 reported that drivers with ADHD are twice as likely to be involved in motor vehicle accidents compared with non-ADHD drivers. Furthermore, Fisher et al. 2007 found that young adults with ADHD were involved in a greater number of minor accidents. They had more license suspensions and revocations, and they made impulsive driving errors more frequently and showed less safe driving habits compared with young adults that did not have ADHD. During laboratory studies using driving simulators, Biederman et al. 2007 also found that individuals with ADHD are more likely to experience collisions during monotonous driving segments compared with non-ADHD controls. These collisions appear to be fatigue-related and occur more frequently during the early morning and late evening. However, Graziano et al. 2014 found the risky behaviours of individuals with ADHD are not related to their symptoms themselves, but to the ability of the individuals to deal with their impulsivity in situations with more or less immediate gratification, depending on their sensation-seeking tendencies and effortful control abilities. Neurodevelopmental dysfunction, such as ADHD, is one way in which people can present with risky or dangerous driving behaviour. Another way is under the influence of mind-altering substances, such as drugs and alcohol, resulting in cognitive impairment to the individual. By participating in the consumption of drugs and alcohol, young and inexperienced drivers are inherently partaking in risky behaviour. According to several studies, the riskiest drivers are young people during their first month driving unsupervised in traffic. According to Pava et al. 2013, young drivers are characterized by sensation-seeking, which leads to risk-taking for the sake of excitement. Furthermore, inexperienced drivers may not fully acknowledge the danger of impulsive and thoughtless decisions while driving. For example, passing other vehicles when it may not be safe to do so, or driving after drinking alcohol or taking drugs. In addition, other studies have shown that young drivers demonstrate lower levels of impulse control and constraint in comparison with more experienced drivers, both of which are psychological factors that predict risky driving and may explain the reason that young adults consume mind-altering substances before driving a motor vehicle. Many studies have established that driving performance is impaired by drugs and alcohol, even in low dosage. Alcohol is a drug whose main effect is on the central nervous system. Unlike anesthetic agents that depress all brain functions, the effects of alcohol are first manifest in the brain centers involved in highly integrated functions, such as skilled performance. The analysis of sensory information, the control of intricate movement patterns, and short-term memory are especially sensitive to alcohol. According to Moskowitz and Robinson, 1988, the effects on human skills and performance commence at the lowest measurable blood alcohol concentrations and increase in a roughly dose-related manner. It is therefore reasonable to assume that alcohol-induced driving impairment in inexperienced drivers is a very dangerous risk to their driving capacity. After discussing the relative risk of neurodevelopmental dysfunction on young driving behaviour, as well as the impairment caused by the effects of alcohol, I will now discuss the services available to address this issue in reference to evidence-based practice. Regarding the recommended practice surrounding the treatment of neurodevelopmental disorders, it is suggested that young adults and their parents or carers should be counselled about the possible driving risks associated with ADHD. In terms of contingency management, Barclay and Cox, 2007, report that behavioural interventions have proven to be largely ineffective, as treatments that are needed to alter the driving behaviour of individuals during times of motor vehicle operation would require caregivers to be always present to apply the interventions. At present, Barclay and Cox, 2007, suggests that medication is the only treatment that meets the requirements of ADHD intervention. Therefore, it may offer some hope for improving driving performance and reducing risks. Regarding the available services aimed at reducing alcohol and drug intake for young drivers, education and law are two general approaches that have been used in efforts to prevent drug and alcohol-related problems in young people. The legal approach emphasises restricting the blood alcohol content limit of young drivers in a bid to enforce better decision-making processes. The educational approach, however, suggests that successful interventions should focus on primary prevention, because it is easier for a person to avoid forming a habit than it is to change a pre-existing habit later. In addition, risky driving has been decreased successfully by such indirect methods as teaching social competencies and relaxation skills. In general, teaching behavioural methods for controlling risky behaviour is a more effective approach to the prevention of crashes than attempting to change underlying attitudes. In conclusion, I reiterate that the problem of risky behaviour in young adult drivers is complex and multifaceted. It is only through a multidisciplinary approach that we may shed light on the best way to address all the issues involved. Thank you for listening.